And thank you, Ravi, for setting the stage for me, because this talk is actually to be given by Linda Scholl-Lesserson, who does a lot of work, and Ravi has showed her paper as well. And Linda was quite keen to come for the event, but unfortunately had a severe otitis media, so cannot fly. So she just emailed me a week ago and said, I'm trying my best. I will try to come on 18th, but I cannot come for the workshop where she was going to contribute as well. But then I said, don't worry, you just send me the talk, because having worked with Ravi, I was quite geared up with all these things and actually confused as well, as Ravi has said, whether you should use point of care devices or not, because outcome wise, does it make much difference? And as an Indian mentality, we will say then why we should spend all that money when we are not going to come up with any good results out of that. So thanks to Linda for the hard work she has done. And as we all know that it's quite a delicate balance between anticoagulation and hemostasis. Normally in our body, the systems are designed in such a way that there are procoagulants, but the anticoagulants always work over them and try to prevent all those things, unless there is some pathology. But when we do some disturbances, say for trauma, for even an operation is the elective trauma, so we can cause all these problems. There can be too much of bleeding, or there can be hemostasis if we use the drugs inappropriately. And that's where the point of care devices are more important. So who is at risk of bleeding and in transfusion? We all know that the patients with preoperative anemia, preoperative coagulopathy, small size females, longer CPP times, double valves, replacements and things like that, aortic surgeries, and all these things are going to cause trauma to the blood elements because of the use of CPP. So how we are going to manage this? So the patient blood management, every day we do this. It's a multidisciplinary interaction. The surgeon is the important aspect, at least in theater, and before that, the physicians and us as well. So basically there are three pillars of management. One is preoperative optimization of red cell mass, then the perioperative reduction in red cell mass, and finally the perioperative optimal treatment of anemia and the various blood products that are required for effective coagulation. So we'll just have a look at this triad and consider the patient blood management in cardiothoracic surgery. So first part is the preoperative anemia, and Achal Dheer is going to talk on this in the afternoon session, so I will not go much into details of that. But the important aspect is who is going to look at that. First is the initial physician or the surgeon who is involved. The medics, they are going to look after this anemia part. And as a preoperative checkup, we, the anesthetists, are going to look into much details of it. The surgeons are usually aware of it, but the people who are going to take care is the physician and the anesthetist predominantly. Then we come to the blood conservation, which is an important part during the procedure. So surgeon has to take the major part of it because he is the culprit for all that. And there is always anesthetic bleeding and a surgical bleeding at the end of the procedure. We always discuss that. The perfusion is also an important aspect in this particular pillar. And then the final post-op management, wherein the ICU consultant, if there are separate people managing it, there are concepts about managing bleeding and how to control the things. And the anesthetic, if there is good anesthetic input, probably what Ravi has shown that it can work in a better way, because the same team continues in the ICU as well if they are managing the post-operative unit. So again, if you look at how we are going to do this, in the initial half, as I said, it's the anesthetic surgical, and the predominant part is run by the medics and the cardiology physicians. In the intraoperative period, surgeon and anesthetist and the perfusionist. So it's an interaction between all these three pillars that is going to give us a better blood conservation and better blood management after the operation. Are there any guidelines? Yes, there are guidelines published, and the main lead was taken by the surgeons. So the Society of Cardiothoracic Surgeons came out with the first guideline about it's evidence-based surgery. So it's a workforce on evidence-based surgery. They came out with this in 2007. But again, by 2011, that come to an update for that immediately. The workforce again started working because probably the point of care devices were used much more rapidly and the understanding of various drug medications was better. So the surgeons had to do this and they updated it. So I don't know whether the guidelines will be updated again and why all this is going on. That's predominantly because of the interventions that are aimed in reducing the bleeding and increasing the important part of quality improvement. And that is the key why we go for blood conservation techniques. And Ravi has shown that the post-operative re-exploration patients have more problems and the recovery is a bit disturbed. So what the guidelines say? They say about the red cell, we'll go one after the other. The red blood cell transfusion, they say if the hemoglobin is less than 6, it's reasonable and life-saving. The level of evidence is 2A, class C. If the hemoglobin is less than 7 grams, the treatment is reasonable in most post-operative patients, but there is no high level of evidence, unfortunately for that. Hemoglobin more than 10, most of us will not transfuse unless there is a patient with critical non-cardiac end-organ ischemia. So, if you look at the level of evidences, most of them are class C evidences. Transfusion triggers during CPB, surgeons have come out, the guidelines has come out with that as well. So hemoglobin less than 6 is reasonable except in patient at risk of decreased cerebral oxygen delivery. Hemoglobin more than 6, it's again reasonable depending on the patient factors, SVO2, etc. We are doing when the perfusionist can actually check it online, the SVO2. And less than 7, it's not unreasonable in patients with, again, the critical non-cardiac end-organ ischemia, especially CNS and gut, where we are worried about, and the kidney function. So the level of evidence in that case is, again, class C, and the level 2A to 2B. Before going on to, I will just touch this restrictive and liberal strategy, the STIT RE2 trial, which is from UK again. And it was a big multicentric study. It was a randomized study. In the cardiac surgical patients, the number was 2007. And the endpoint was post of hemoglobin. That's what they looked at. And the liberal transfusion group, if the hemoglobin is less than 9, they all got blood transfusion. In a restrictive group, definitely they saw that the hemoglobin is less than 7.5. And the outcomes that they looked at is infections or any ischemic events within 3 months of operation. And the secondary outcomes was transfusion, length of stay, adverse renal, pulmonary, and mortality related to these things. And the final aspect was the cost analysis. So what they have come out with it, if you go through that, actually the restrictive transfusion threshold was not superior to liberal threshold with respect to morbidity and healthcare cost. And why is that? If you look at that, all-cause mortality at 90 days was actually more in the restrictive transfusion threshold. So it's a paradox that you try to prevent more of transfusion because it causes more problems with transfusion-related infections and things, and actually the death rate is more in that group. Where there are some limitations for that, it was difficult to blind the personnel in this particular trial. The groups were similar. Most of this trial was specifically designed for cardiac patients because in cardiac patients usually we don't want to cause oxygenation problem with myocardium per se. So we are more worried about oxygen delivery and we tend to keep slightly higher hemoglobins. Rest of the studies which were done in surgical patients, they have not considered that factor, and they have always shown that restrictive transfusions were a bit better in outcomes. But this trial has shown that the restrictive transfusion is probably not as good as, and the results with liberal and restrictive are the same. Let's look at another trial which is going to help us in controlling the bleeding during and after cardiac surgery. So there are 3 pillars again: the pharmacological, the technology, and the physiology which the body normally has. And again, the same people are going to work on that. So in blood conservation, let's look at the technology part of it. Red cell salvage, they have come with class 1 level A evidence, centrifugal pumps which are being used, class 2B, level B, heparin coated circuits, and so that reduces the amount of heparin, class 2 level B evidence, and packed red cells with adequate platelet yield, it is going to work well. Why this is, these two, the arrows indicate that there is a change from 2007 to 2001 guidelines in the STS guidelines which we have seen. The perfusion techniques, have they changed a lot? Yes, there are a lot many circuit modifications. There are many circuits, and that has given the level of evidence from class 2 has moved to class 1 in the updated version. Pre-donation EPOs, there is class 2 evidence, level A evidence. Intraoperative salvage and autotransfusion, it has come up with the good evidence as well. Retrograde autologous prime, personally I have not seen this particular thing on how the perfusions are using, but that is one of the way of reducing the, improving the perfusion volume and taking the more of the crystalloid part out of the circulating volume. Hemofiltration, especially modified ultrafiltration, has got a good level of evidence, and washed shed cells, which we are normally using via the cell saver, and the products, the blood that remains in the CPB circuit, if you're going to take it, just don't, rather than centrifuge it and then give it to the patient, rather than giving it directly to the patient, that has definitely shown a good level of evidence. So all these perfusion techniques are going to be more useful, and that's what they have suggested in the STS guidelines, that we should follow these techniques in order to improve the conservations. What is the role of off-pump cardiac surgery? This class 2 level A evidence, and we have seen that there is a big study from Cheng et al. And what they have shown actually is the atrial fibrillation incidence and the transfused patient, that was quite significant. Rest of the parameters have not changed much, whether you use on-pump or off-pump surgery. But looking at this particular blood conservation, if you look at the transfused patient, then it is quite significant. Let's go at the look at the drugs used for blood conservation. And predominantly the drugs which are used is antifibrinolytic agents, the lysine analogs and kallikrein inhibitors, DDAVP for platelets, procoagulant agents which are useful when there is, we lose most of the control on the coagulation. So recombinant clotting factors, prothrombin complex concentrate, fibrinogen and thrombin. And basically what Ravi has said is monitoring the procoagulant agent, because that is an important aspect. When you are using some procoagulant agent, you should limit it, otherwise you can have a devastating problems with it. So what are the antifibrinolytic agents? As we all know, the coagulation pathway and the way platelet gets activated and they contribute for the coagulation. So all this tranexamic acid and epsilon aminocaproic acid, they work for us for on the plasminogen, and the protease inhibitors, they are working they are acting at these different locations in the coagulation pathway. So if you look at the pharmacology of it, the antifibrinolytics, aprotinin, which unfortunately went back because of the famous trial and it was blamed a lot, but I think aprotinin is coming back into, at least in some centers they are coming back. So the class of evidence as class 1 for aprotinin was downgraded immediately after that particular study, but some centers are looking into that again. Use of factor 7A is not unreasonable for the management of intractable non-surgical bleeding, which is unresponsive to the routine hemostatic therapy after cardiac surgery. There is no change in that. They are still guarding against with that, and especially the dose, the mean dose is described around 59 rather than 90, which was described before, because the dose of 90 milligrams per kg can cause more problems with factor 7A. And let's look at a CPB and a platelet effects. What is going to happen? These are the important receptors on the platelets, for which all the cardiology community is working. And the CPB also affects various other platelet the various drugs which are used for GP2, GP3A The STS has given some guideline about that, and what they say is the thienopyridine agents you should discontinue for 5 to 7 days. That's a class 2 level B evidence. The newer drugs, ticagrelor, especially in emergency situations, if you are going to use, then you prefer ticagrelor rather than clopidogrel, because if you want to do the emergency surgery, at least you have some chance that the half-life of the drug is much less. So the discontinuation of thienopyridine as short as 3 days has class 1 level B evidence, in the sense that if you don't discontinue them earlier, then there is definitely increased evidence of bleeding if the duration is short, and that's why that has a class 1 evidence. Aspirin in purely elective cases you can discontinue, but as you know, there is a big study from Paul Moll from Australia, and they have discussed this issue about continuing aspirin in the perioperative period as well, because it has worked. They have a big study about aspirin and ESAs or tranexamic acid. Then heparin protamine management again has a class 2B and level B evidence. What is the situation in India? In India, what people have done is there was a multimodality blood conservation strategy in an open heart surgery audit in AIMS, and what they have done is it was a retrospective audit. They took about 310 consecutive patients, and they had a criteria for transfusing blood products. Before that, they had defined that when they are going to use which patients will be selected, and there was standard pre-optimization for all the patients, and the specific criteria that they have used is packed red cells were given with the hemoglobin of less than 7, hemoglobin less than 8 after discontinuation of CP bypass, and chest tube drainage. What Ravi has also said, that why we should consider giving transfusions based on these things. And they have found out that the 82% there was no use, and in 17.6% there was use of transfusions. At the end of the day, they found that the mean hemoglobin was 9.8 gram% in the study, and they could significantly bring down the use of blood in the perioperative period. In non-cardiac setups, is there any work in India about it? So there is work. They did the appropriateness of perioperative blood transfusion in patient undergoing cancer surgery in Bombay, and it was a 3 months period which was contributed to the prospective study. So they took around 1,000 patients in that, and these were all elective cancer patients, and the post-op hemoglobin was supposed to be around 10 grams per deciliter. What has happened is, if the hemoglobin is more than 10, they will consider it as over-transfusion. So if somebody has given a transfusion during the procedure, and after the procedure, if the hemoglobin comes as 10 grams on day 1, then it was over-transfusion. So in conclusion, what they said is, the perioperative transfusion rate in patients undergoing cancer surgery was 16%. It was similar to the one which we see as the AIMS study. More than half of these patients were over-transfused because their hemoglobins were more than 10. So following the audit, they say that what was the use for doing all these things? The point-of-care facilities of intraoperative hemoglobin measurements have been introduced in the particular institute. So what Ravi said about one of the studies, that they were doing a novel way of introducing the newer technology in the working facility. Probably that's how they have changed the mindset in Tata as well. Finally, the monitoring of pharmacological agents, predominantly the point-of-care equipments, and there are some examples for that. There's a case report by Hendricks. This was a difficult to wean, complex, multi-valve, poor LV patients from CPB, and he had received an aprotinin bolus at the start of the case because it's a multi-valve case. Upon weaning from CPB, he required multiple nanotropes and was still bleeding. He was given all the blood products listed above, plus another load of aprotinin, and he has received 30 RBCs, 20 FFPs and thing, and look at the tag at the end of that. So there is something seriously wrong. So what we can do? The only option they had was to use a procoagulant. And what they tried, after 90 microgram per kg dose of factor 7A, the bleeding stopped, and there was much less bleeding in the next 12 hours. Though the number of products they had used was the same, but the TEG which was there had significantly improved after that. So there are many reports after the introduction of factor 7, and that's how now factor 7 use has been restricted. As I said, the mean dose is around 60 micrograms, is far better than using a bigger dose of 90. Are there any in vitro studies done? Yes, there are some studies done, and especially with platelet, if you add some TPA to a plasma, Tanaka et al. Did a study, and if you add aprotinin to that blood before introducing TPA, they have shown that there is definite evidence that this point of care machines are going to be useful in determining the perioperative coagulation. So what is the role of all these medications in the perioperative period? According to various studies, prothrombin complexes, these are essential coagulation factors which are 2, 7, 9 and 10. The dose is based upon weight and the factor 10 content. There are some anticoagulants in the mixture as well, which are protein C, protein S, antithrombin 3 and heparin, because as we all know, AT3 is equally important for coagulation. 3 factors versus 4 factors, there are some combination which will have 3 factors, some will have 4 factors. The things available in UK are octiplex or bariplex. Ravi, you can correct me if there is some problem with the names. And in USA, there are these 4 preparations that are available. They are predominantly useful for in cases of hemophilia, and they are approved for that. They are approved for warfarin reversal as well. But the risk of thrombosis is 4 to 8 per 100,000 patients.
We're a little time up, so yeah. If you could just
few.
Yeah.
So what they are saying is PCC for urgent warfarin reversal, there is a good evidence for that. Use of factor 10 concentrates, combination of clotting factors, there is a good evidence for all that. And the ESA guidelines also say that patients on oral anticoagulant therapy should be given PCC and vitamin K before other coagulation management steps for severe perioperative bleeding. The fibrinogen concentrates in humans, there are various options available for fibrinogen concentrates, and why it is important, that's the fibrinogen supplement can augment clot strength in cases of severe thrombocytopenia. And if you show you one of the slides, this is one of the studies they have done in the dilutional coagulopathies, especially if this is a baseline. If you dilute the blood and see what is going to happen on the microscopic picture, and if you add some fibrinogen, that is how even if there are low number of platelets, a good amount of fibrinogen will bond them quite well, and that's the important aspect of using fibrinogen. So finally, to conclude, blood conservation in cardiac surgery is multidisciplinary. There are 3 aspects of it: use of technology, use of pharmacology, and the clinical management. So there can be individual variations about giving what the products, and point of care machinery probably will be more useful for that clinical decision making. And it should be, the patient blood management should be evidence based. Safety of PCCs, fibrinogen, antifibrinolytic, and other hemostatic agents is still, there is debate going about all these things, but there is a good amount of evidence that if you use them carefully, they are not going to be harmful to your patients. And I think still feel the point of care testing is need to monitor all the effects of especially the procoagulant drugs. And I thank you all for the patient listening.